Good afternoon, my abnormal behavior class. This week we talked about GAD, generalized anxiety disorder, and most of you did very, very good on your post. I just want to remind all of you, you need to give me some more substantive posts. A, that I know what you're understanding, and B, that you've really read the text. So when you say, yes, I agree, I'm not getting it. So if you want all the points, and again, 50 is the minimum, but you really probably need to give me a little bit more. So let's work on that if you want all those points. Just going to do a little clarification on generalized anxiety disorder. At this stage, you are not expected to diagnose. That's not what we're looking at. If you decide to go into a clinical social worker and bill insurance, at that point you will take some classes where you'll be able to diagnose. However, you will see these patients, and you will see the DSM, and you will see the Axis 1 in the back of the book. That will be assignments. So I just want to really kind of talk to you what GAD is and what it looks like, and just make it some really clear for you. I promise you that as you go along through the text, you will have everything. I remember back in my class many years ago, I was so sure every time we came to a chapter that I had that disorder. There's real differential diagnosing that makes it a whole lot easier, and I promise you, you don't have everything. So one of the ways that we really diagnose for generalized anxiety disorder, and what you'll see also is you'll see the 300.2, that is the code. So when you go to the doctor and you have an upper respiratory infection, and there's a code that goes with it, that's how you bill insurance. So one of the reasons that we use the DSM is so there is a billable code for insurance. There are lots of pros and cons of having that. And certainly some doctors, therapists, social workers who will use a code when definitely may not be appropriate, so the insurance will pay for it. But the diagnostic criteria is excessive anxiety and worry, apprehensive expectation occurring more days than not for at least 6 months, and a number of events or activities such as work. So not only is it one period of anxiety, it needs to happen for at least 6 months, and occurring more days than not for at least 6 months. And it's a cross activity. It can't just be at home. You'll see it at home, at school, at church, in your car, wherever. That's one way that we differentiate. The person finds it difficulty to control the worry. Anxiety and worry are associated with 3 or more of the symptoms. So just look at these symptoms: restless or feeling keyed up or on the edge, being easily fatigued, difficulty concentrating or your mind going blank, irritability, muscle tension, and some sleep disturbance. So what we look for is, out of those, at least 3 of those for a period of 6 months across environments. The focus of anxiety is not confined to Axis 1. That's a level 1 diagnosis. We'll talk about that later. And there definitely are some other mental health labels that definitely go along with the anxiety. We talk about some social phobia, panic attacks, obsessive compulsive disorder. Obsessive compulsive disorder is an anxiety attack or a bout of anxiety. So most often the obsession is the thought: I have to wash my hands, I have to do this, I have to do that. And if I don't act on that, then my anxiety increases. So the compulsion is to act on my obsession. So, people who, my neighbor has to make sure her garage door is locked. So I didn't realize this before. She would come down and she would drive around the corner and go back. So her anxiety, which is her obsession, her thought is, what if I leave the garage door open? What if I leave it open? So the compulsion is to drive by the house twice to make sure it's closed. So usually if the obsession and the compulsion can fix each other, that decreases the anxiety. But if she had the obsession and didn't go back to check, then her compulsion would grow and grow. She wouldn't have the compulsion, and her anxiety would grow and grow and grow. So that's what that looks like. And again, this is from the I won't take credit for it. It is from the American Family Physician, and it's generalized anxiety disorder, and you can see the webpage right there. So I'm not pretending that I wrote this. It is definitely a really good article. It goes on in tandem with your book. Also, then we have some symptoms and behavior that are associated with generalized anxiety disorder. So you have excessive psychosocial arousal, muscle tension, fatigue, restless, insomnia. Those are body parts that are related to anxiety. So certainly it's that mind, body, soul connection. So when I'm more anxious, that feeling, then sometimes I'll see you. I'll see you underneath the desk, tapping your feet or wiggling your legs. Some restlessness, insomnia. Sometimes it's insomnia or hypersomnia. You sleep all the time where you can't sleep at all. Your cognitive processes, and that certainly is your thought process. You have poor concentration, unrealistic assessments of problems, and worries. We'll talk a bit later about how we really treat some of the disordered cognitive processes. But one of the ways we treat that is really kind of doing a realistic assessment of the problem. I had a client one time, and we kind of talked through her anxiety. She wanted to do very well, a very perfectionist kind of person. Every night before she went to bed, she made sure that she bleached down the entire house. She couldn't go to sleep without it. And then she was trying to take care of her children and work, and got behind in school. And and I said to her, "Don't worry, it's more important that you're dad. Just relax." And we kind of role played of what would happen if she didn't. And I would say, "So what happens if you don't bleach the house tonight?" Then she would say, "I can't sleep." And then what happens if you can't sleep? Then I can't do my homework. Then I can't come to school. Then I'll be a waitress forever. Then I'll be a failure. So it's really very unrealistic of what happens if you don't bleach the floor. It quickly went from not being perfect to my entire life being over. And that's just not realistic. And worries. Also, some of us have very poor coping skills when it comes to anxiety. We just avoid it. If you have a social phobia, a social anxiety, you just avoid social situations. We procrastinate. Anything that we don't want to do, we put off to the end. And we just have some really poor problem-solving skills. Again, with my client, that just didn't make sense of how that would work. So those are the kind of things that we look for. Also, when it comes time to actually evaluating it, so what we do is we do a full assessment with everybody. As you read in the textbook, we talked about Adrian. Adrian was a 39-year-old Caucasian with 2 children, a son and a daughter, and she had some issues. So you'll see where she went to the therapist, the doctor, to really get a good assessment. Patients with anxiety worry, their nerves are bad. Sometimes they have poorly explained physical symptoms. Can I tell you how much we would save as a country if people who thought they were having panic attacks realized it was just anxiety before they've spent hundreds and hundreds of dollars on a medical test? And certainly when you have a panic attack, which is, again, just anxiety, I don't think it's just anxiety, but it is anxiety. It's like your heart's going to pound out of your chest, and you can't imagine why everyone else can't see it. But again, most of the time we go through all the tests, and it's psychological. So the first thing we do is evaluate for medical illness. We evaluate the over-the-counter medicine. Sometimes the doctor will say, how much coffee do you drink? Are you on any kind of illegal or even some overuse of legal drugs? We're going to evaluate for the presence of some social support. Like, what do you do when you get anxious? Who do you call? What is your support system like? If you're having true anxiety and you sit in the house all day and wait for it to go away, we're just going to assess that. We're going to maybe evaluate with some worry. We'll show you that in a little bit. And then remove substances and or medications. So if you look at this one, so how we evaluate for a panic attack, and then we evaluate for symptoms of major depression. So again, panic attack, this is a differential diagnosis. So if they have a panic attack, we're going to treat for that. If they say no, we're going to treat for GAD. Here, you'll see major depression or GAD. We know that anxiety and depression many times look very much the same way. So we're going to sometimes treat for the depression. The difference in medication is that antidepressant takes a while to get in your system, many times 2 weeks. However, it doesn't have the addictive qualities that many of the anti-anxieties do. Again, you can read this about the initial assessment, which is, again, very much like Adrian in the textbook. The doctor or the social worker, the counselor, is going to evaluate for substance abuse, because many times coming down from a substance or being an addict it really will cause you to have some anxiety disorders. Also, when we looked at family history or looked at the health history, many times there are some hormonal changes, especially with women, that can lead to some anxiety. We look at that around the menstruation, some maybe some increased anxiety sometimes that are very much related just to your hormones. If we look at the distinguishing table, again, we can look at this. It talks about how we distinguish things. So generalized GAD, which we talked about, is just to worry about a specific concern about your early 20s, you're restless, some motor tension, some fatigue. Chronic means it happens quite often. And then if you want, many times you'll have a family history of it, or also of alcohol and drug abuse. We think many times that people who are using the downers, alcohol and drugs, really are just self-medicating when it comes to panic disorders, or I'm sorry, generalized anxiety disorders. So you feel that way, and that antidepressant, that drink, that beer tends to bring you down. We also know that a lot of our mental illnesses are definitely genetic, that we've inherited from the mom, our parents. There are some studies that look at whether it's nature versus nurture, but definitely we know there's a piece there that is genetic. So then a panic disorder, that's a very different. A panic disorder is intense, it's brief, it feels like, again, like you're having a heart attack. That's why many people end up in the emergency room. It usually doesn't happen until your mid-30s. You've got a rapid heartbeat, and again, you feel like it's like jumping out of your chest. Periods of remission and relapses. Again, same kind of thing. We're going to look for a history in the family of some panic disorder or depression, or maybe it's in substance abuse. And then we have major depression, which is kind of always just a low mood, just not having the energy, and not just bad days. We all have bad days. We all have grief when something happens. But major depression is just a period of always kind of feeling that way. We talk about people who are being suicidal is that major depression kind of never seems to go away. It happens most of the time in your mid-20s. We get some neurovegetative symptoms, insomnia, lack of appetite, some guilt. Again, hypersomnia, which is oversleeping, is also very common in major depression. The symptoms remit, which means they let go a little bit, but most often they reoccur. And again, some family history of some of those kind of things, what we look for when we're doing a full assessment of that issue. And then a couple of you talked about, using some pharmaceuticals for treatment. That is very, very common. That is not usually the first choice. And we know that if we have a family member with a history of substance abuse, our first choice is not going to be an addictive benzo. We're going to look for some of the other things. But this is just kind of an idea of what to look for if you do have someone who is on some of the benzos. And they are... For most clients, they are addictive. We've done some research on that. Before, we used to give it up pretty easily, but we do know there's a very much an addictive quality of that. So just a little heads up on kind of GAD and what it really looks like. Again, this is the website. I'm going to post this, and you're going to have to give me some feedback in the blog area. Remember to blog to your peers as well. Wow, I didn't know this, or this is pretty exciting. So again, the goal is to be just as interactive as you are in the actual classroom. So enjoy it. If you have any questions, again, shoot me a question in the blog. And when you log in the blog, make sure that you are logging into everybody's. Let me just clarify this a little bit. So let me show you when I say blog, many of you probably are not sure. Okay, so here on the home page, there's a blog, and these are my blogs. So you can see what I have blogged, like a lecture, and this one will be there. Emails or announcements. Let's go back. Okay, so you will see my blogs, and you'll see what I have in there. Blog here. And then a dialog will open here, and you can see that I have blogged one time, and the date is there. So I know that Rebecca has blogged 3 times. So what I expect you to do is to blog here, and then to be sure that you read other people's blogs. If you hit there, you can comment. And like this was the 17th, and did some questions about my Facebook page. Can you put the link down? She couldn't find it on Monday. And I don't know, it's Case Knows, and I'll answer that, but I don't think, I usually put a YouTube link on there because many of you aren't on Facebook. So it's easier to find the YouTube link, and they're also usually in your email or as well as posted in your announcements. Okay. Hope that you enjoyed your time off with the snow and that we don't get too far behind. Have a great, great day, and hope you have a better understanding of GAD. Thanks, guys.